Victoria Parikh, Mike Gibson coming to you live from ACC 2026. And this is fascinating. Arrhythmogenic cardiomyopathy, we're on the RV side, and gene editing. Victoria, talk to us a little bit about, the arrhythmogenic cardiomyopathies. How many of them are there? How prevalent are they? And what you did.
Yeah, thanks so much for asking, and it's really wonderful to be able to talk with you about this work. So, arrhythmogenic cardiomyopathies, in particular ARVC, as cardiologists, we think of these as really rare diseases, but we know that there are up to 60,000 people in the U.S. who might actually
Wow.
be affected.
I
Uh,
didn't know it was that many. I
yeah,
thought, yeah. Does
yeah.
that qualify as a rare disease then? Does that exceed the rare disease threshold?
It's a great question. So that's a for ACM, I think overall, right? And so what we're talking about for this particular trial is a specific genetic cause of this cardiomyopathy, and that's by plakophilin 2. Now, this is the most common cause, but I think that what we're talking about is certainly still a rare disease, right? We're talking about, less than 2% of the population. But that this particular indication is still a very common cause of the disease
How do
within.
people know they have this? I mean, how do they present? What are the symptoms?
Yeah, it can be really devastating, Dr. Gibson. You definitely see patients presenting with sudden cardiac arrest and death in the most severe cases. And then many of the patients that we see in clinic are, for example, marathon runners or really healthy, long range cyclists who are walking into an ER with prolonged VT in the 200s, and they feel terrible, but they don't know exactly what's wrong, right? And so it is really a very scary thing, and we want to make sure that we're presenting or preventing that sudden cardiac death. And then, of course, the progression of the disease toward RV failure is something that we see more and more.
Are there any EKG signs? Now, there's, of course, cardiologists looking at the EKG, but these days, using AI, AI can tell you, if you had recent AF looking at your EKG. So are there any AI techniques under development to kind of detect some of these rare arrhythmogenic cardiomyopathies?
That is such a great question. There are certainly really pathognomonic signs in the ECG, which include mostly T-wave inversions, and then of course there's the
Oh,
epsilon.
I hate to hear that because all I do is say non-specific T-wave conversions. I
I know.
never read it.
I know. So I think you're right. This is an area that's really rife to be able to say, is this a T-wave inversion due to an ischemic cardiomyopathy, or is it a T-wave inversion due to ARVC? Certainly, just by eye, even without computer vision, we can tell that those T-wave inversions that are more in V1 through V3 are going to be those that are affecting the RV, and then those that extend out, of course, to V6 are going to be more of an LV predominant disease.
All right, so talk to us about this gene therapy. Sounds exciting.
Yeah, so it is really exciting. It really is the idea that these patients that have this disease are missing a copy, missing a functional copy of this plakophilin 2 gene. And so because that's broken, then they are sort of bereft of the scaffold of the cardiomyocyte, the heart cell that holds the heart together, right? That allows these cells to talk to each other in a way that propagates the electrical signal that we know is so important for keeping us in rhythm. And then, of course, in the long term, for keeping our function of our right ventricle and left ventricle intact. So, what you can do then is you can actually deliver a functional copy to replace that broken copy. And so, the way that that's done here is with a particular viral capsid. This is an adeno-associated virus. So this is not a virus that's replicating, it uses a delivery mechanism to the heart. And it turns out that because this particular viral capsid, which is AAVrh10, is actually very efficient at getting that piece of DNA into the heart, you don't have to use as high dose as you might for other viral capsids. What that allows us to do is deliver that gene without having to massively immunosuppress, although of course we still have to use some immunosuppression in these patients, and also really reduces the risk of some of the really devastating outcomes that we've seen in other diseases with these viral deliveries. And so what we're seeing in this trial is that this has been really safe, that we are not seeing any complement activation or any of the sort of immune overactivation syndromes that we've seen in other gene therapy trials.
Yeah, a lot of people say they're doing gene therapy, but they're not really doing gene editing. They're doing some post-translational kinds of therapies. This is really editing the gene, which is very exciting. How do you know it worked? I mean, are there, when you're altering the structure, are you altering anything phenotypically that we could see in a biopsy, or is it just truly kind of something you would see electrically?
Yeah, so that's a great question. When you deliver this copy of DNA, you have to be able to tell if it's actually turning into that protein, right? And replacing that scaffold. So in this trial, we measured in three different ways whether or not the virus got to the heart, whether or not it turned into that RNA. We always talk about the DNA to RNA to protein, right? Back to basic biology, whether it turns into that RNA, but then really importantly, does that RNA replace the missing protein, which is what we're looking for. So we definitely see increase in all the patient biopsies that were done 3 months after delivery of the therapy. Increase, we see the virus in the heart. We see an increase in the RNA level from the vector itself, from the drug. And then in 5 out of 7 patients, we are definitely seeing increases in protein expression. And so I think that is really critical because we're not just seeing marginal increase. We're actually seeing these patients go up by almost twofold, and in some cases as high as sixfold.
I'm just a dumb guy from Oklahoma. Let me ask a couple dumb questions. So, you hope this virus gets into all the heart cells, right? And
Yeah. Yeah.
do we know if it does get into all of them? And if it doesn't get into all of them, if it just gets into some of them, is it a good thing to have different islands of some things working electrically well and other areas not working well electrically? And can you get some arrhythmias if you don't get it all right?
That is a brilliant point and a really important question that many, many people have been thinking about and trying to sort of computationally model. What I can tell you is that in the animal models, we see very diffuse distribution of the virus, right? And of the protein expression itself, which is very encouraging. The idea that we're getting sort of spotty delivery, I mean, we know, it's not just the LAD dumping out into one piece of the heart, right? We're getting into these micro vessels, right? And we're really getting good distribution. We don't see, I think, among these 7 patients that we're going to report on any increase in PVCs or in NSVT, which I think is really encouraging that we are not putting the heart into that state where there are all these new re-entry events that folks have been concerned about. And I think that over time, we need to see how these patients continue to do in terms of whether we are arresting progression or improving outcomes for them.
And how do you give it? You just kind of touched my heart when you said you give it down the LAD. Do you give it down the LAD as an intracoronary injection, or how do you give it?
Yeah, this is such an important point. So, there are certainly some trials that give it, into the left main, right? And also into the RCA intracoronary delivery. Overall, I think that the data suggests that much of that becomes systemic anyway, right? And so, because you know better than anybody how quickly blood's moving through a healthy open coronary. So we gave it intravenously, systemically, and I think that that's an important point, right? Because many of these diseases will also, as we expand our gene therapies, many of them will also affect skeletal muscle, right? And
Hmm.
so it's actually a good thing that it becomes systemic for many
Hmm.
of the proteins that are expressed both in the heart and in skeletal muscle.
Well, if you inject it down a coronary, there's all kind of stuff going backwards and effluxing. But, if you blow a balloon up and deliver it more locally, you can prevent that. So,
Yeah.
well, I got to tell you, I'm absolutely fascinated by what you presented, Victoria. This is so groundbreaking. There's so many different diseases out there, like hokum and this, and so many diseases of the myocytes that could benefit from this kind of targeted therapy that you're talking about. Great stuff. Look forward to seeing what you have in the future.
Thank you so much, Dr. Gibson. Really nice to meet you.